I'm just going to cover briefly, why does it matter, lipid management? What are the current recommendations? How does this fit in with QOF and tools to help with dealing with this? So apart from hypertension, it's probably the most important thing we can do in primary care to prevent cardiovascular disease. The problem is the numbers are huge and primary care is completely drowning with all the other work. This is a kind of rough schematic of lipid management in basic terms. So you've got three groups of people really you need to be thinking about. You've got your people with established atherosclerotic cardiovascular disease. And in general, the default is they're supposed to get atorvastatin 80 milligrams. Then you've got your people who are known to be at high risk and who should be considered for primary prevention. And essentially, that's anyone with a Q risk more than 10%, anyone with significant CKD, anyone who's reached 85, anybody who's diabetic, that should be 60. So anybody who's 60 and got diabetes, their risk will automatically be more than 10%. And then people with type 1 diabetes with certain risk factors. And the default pathway for those people is that they should be on something like atorvastatin 20 milligrams. Then the final group is the people who probably are eligible for primary prevention, but we haven't determined that for definite yet. To give you an idea of numbers, this is data from County Durham, but it won't be very different in the rest of the county. So in County Durham, about 6.8% of people have got atherosclerotic cardiovascular disease. About 86% of those people have got lipid lowering on repeat. 91% have got either lipid lowering on repeat or they've got a reason why not. So they're terminally ill or they've said they don't want it. And of those people who are getting lipid lowering, about 71% of those people are on high or very high potency lipid lowering. If you look at primary prevention, it's probably about 18% of the population have got established, confirmed high enough risk to justify thinking about statin, but only about 56% of those people are actually being prescribed lipid lowering therapy, and only a tiny number we've recorded a reason why not. And you can see a far lower number of these people, proportion of these people are getting the right intensity statins. If you then look at the people who look like they're high risk, but it hasn't been confirmed, that's about 6.1%. So that leaves us, and 19% of those are already getting statins, but a lot of those, these are people who've somebody's decided they're high risk but hasn't recorded a Q risk score. So if we look at where the biggest prize is, 13.6% of the population, we should be offering lipid lowering therapy, and only 0.6% of those people are secondary prevention. So the vast majority of the work to do here is primary prevention, not secondary prevention. And you can see that the majority of the work to do for intensification of statins again is in the lower risk group. But that will have a bigger impact on population outcomes because the numbers are far higher, and also these people who are primary prevention or as yet unassessed are much younger, they're much have far less comorbidity, and they're going to live a lot longer. So they'll have many, many more years where potentially they might benefit from lipid lowering therapy. This is a diagram of lipid lowering therapy and how much it reduces your cholesterol. So high intensity lipid lowering is defined as 40% or more, very high is 50. So you can see that's atorvastatin 20 milligrams or higher, or rosuvastatin 10 milligrams or higher. So the recommendations now are that, you know, we should be using high intensity lipid lowering for primary and secondary prevention. Essentially, that means we should really only be thinking about atorvastatin and rosuvastatin as initial treatments. So if we just move on to the secondary prevention. So NICE makes it sound really easy that you just give everyone atorvastatin 80 milligrams, but the real world isn't quite as simple. If you actually read the guidelines and the BNF, there's lots of people where atorvastatin 80 milligrams to start with is not necessarily the best option. And it includes these conditions like being older, having CKD, having liver disease, being on other medicines, in particular amlodipine, because a lot of patients are on amlodipine. And if you do a simple search and look for what proportion of people with cardiovascular disease have got one of these conditions, it's 3/4. And if you take age out, it's still a half of patients. And 1 in 7 of those patients with cardiovascular disease is either moderately or severely frail, or is on the palliative care list. So we need to be careful when we're thinking about lipid-lowering therapy for this population. So this is the current pathway for secondary prevention. So if the eGFR is more than 60, the default is atorvastatin, but we need to think about the about those other issues that we just talked about. If the eGFR is less than 60, the default is atorvastatin 20 milligrams. And then you're supposed to check the LFTs and the lipids in 3 months' time and make sure that they're achieving a 40% reduction. Now, this is where there's a lot of confusion with QOF indicators and NICE consultations. So the current QOF indicator suggests that what you should be aiming for is a target of less than 2.5. I'll come on to discussing that QOF indicator in a bit more detail later on. But you can see that there are going to be a lot of people who are coming down this route on lower doses of atorvastatin, and thinking about the relative reduction in their cholesterol is going to be really helpful. So the pathway goes statin to start with. If they can't tolerate the statin, you might try another statin, and essentially that needs to be rosuvastatin. You might try ezetimibe monotherapy, although that almost certainly isn't going to achieve the desired reduction in cholesterol. But if it's the only thing they'll accept, then it's better than nothing. Ezetimibe and bempedoic acid in combination will also give you about a 40% reduction in non-HDL cholesterol. Once you've done this, there are two other treatments, inclisiran and PCSK9 inhibitors, which I'm not going to concentrate on, which are patients are eligible for that if their LDL cholesterol is above certain thresholds. So more than or equal to 2.6 for inclisiran, much higher for PCSK9 inhibitors. The number of people eligible for PCSK9 inhibitors is really, really small. So for primary prevention, just move on. So primary prevention, so that's this group of people that we talked about before. Default treatment is going to be atorvastatin 20 milligrams. Then check the LFTs and lipids at 3 months and make sure they've achieved a 40% reduction in non-HDL cholesterol. The other options for those people are going to be another statin, and rosuvastatin again would be the best option to go for. Ezetimibe monotherapy, although that won't achieve things, a statin plus ezetimibe. And if we go back to this chart, if you add ezetimibe to statin, you basically add 20%. So pretty much any statin dose plus ezetimibe will get you a 40% reduction in non-HDL cholesterol. And again, ezetimibe bempedoic acid in combination is another option for those patients. So just coming on to QOF. So there are 4 QOF indicators that involve lipids. There's cholesterol 1, which is people on the coronary heart disease, stroke register, peripheral arterial disease, or CKD 3 to 5 registers who are on lipid-lowering therapy. But it excludes people with diabetes. It's a slightly odd thing because they don't want to pay twice, and they're claiming that it's kind of within the diabetes indicators. So that's a mix of some primary and some secondary prevention. Cholesterol 2 is just people in the heart disease, stroke, and PAD registers who've achieved a non-HDL cholesterol less than 2.5. And then the 2 diabetes ones are people who are 40 plus without those conditions there, who are on a statin, and it's very much only statins, this one. It doesn't cover other lipid-lowering therapy. And then diabetes 23 is people with diabetes and cardiovascular disease or kidney disease who are on statin. Now, cholesterol 002 is a unique QOF indicator. I think it's a uniquely awful QOF indicator. It doesn't fit with it doesn't sort of follow the rules of any of the QOF indicators we've had in the past. The first thing is that the indicator doesn't actually reflect the accompanying guidance. So the guidance that comes with QOF says you should follow the NICE guideline, which is start them on atorvastatin 80 milligrams or 20 milligrams if their renal function's poor, and then aim for a 40% reduction in non-HDL cholesterol. Whereas the indicator itself just has a fixed target of less than 2.5. The threshold is 20 to 35. I mean, that's really low. We don't have any other indicators which have that kind of low indicator. And it suggests that low performance is what they're expecting. The denominator includes lots of inappropriate patients. So if you've just had a hemorrhagic stroke, then it might not be appropriate for you to be on highly intensive lipid lowering therapy. There are absolutely no exceptions allowed in this indicator. So if you've just had a stroke, if you have a stroke 1st of March, then obviously the sensible treatment would be to put them on a statin and check their cholesterol 3 months later, but you'll miss the QOF year-end date, and so you won't be able to achieve the indicator for that patient. You can't accept people who are terminally ill where it's clearly completely stupid to give them lipid-lowering therapy. So for this indicator, if you achieve 100% performance, it means you're actually delivering poor care, because it means that you're treating people who are very frail and dying, or even testing them, because there's no point testing the cholesterol of people who are dying. You might be having to treat people against their wishes, and you might be testing people far too early after a cardiovascular event. So what I'm going to talk about is the tools and things that we've built to try and help with lipid lowering and all the intricacies of it. So if I just move into system 1, can you see system 1 there? Somebody just...
Yes.
We can see the slide.
Can you see a lipids dashboard?
Yeah, we can go.
Yes.
Great. Okay. So this is the lipid dashboard from my my surgery, and this is on what's called a visualization, which is a new function within System 1, which is a really powerful way of seeing information from System 1, both at the whole practice level and at an individual patient level. So what we can see here is the initial screen is showing me how am I doing with lipid lowering. So I've got 20.8% of my patients on lipid lowering. 86% of those are on high or very high potency treatment. 98% of them are collecting it. 88% have had a lipid check in the last year. 94% of those people have got a target, and this is how I'm doing in achieving that target. Then that's the same information split up into primary and secondary prevention. You can see here the very different profile in terms of how potent the treatment is that people are getting. So secondary prevention, 39% of people are getting very high potency treatment. So that's something that's going to reduce your cholesterol by 50% or more. We can see different achievement. So in terms of how am I doing achieving the 40% reduction target, well, it's about 73% for my secondary prevention patients and about 67% for the primary prevention patients. And then this is the people who are probably high risk but haven't been properly assessed yet, and that's 3.2% of my population. So you can see I'm doing a bit better than the regional figures, where this is more like 6 to 7%. Okay, so that gives you an overview of what's going on. And then these tools here are for what can I do to make things better. So if we take primary prevention to start with, this is separated out into 3 lists, essentially to help you prioritize and delegate this work. So the engagement issues are things that could be dealt with by a non-clinician. So primary prevention patients, there are two searches here. One is people who have got lipid lowering treatment on their repeat prescriptions, but they're not collecting it. You click on the little jigsaw pieces, and that shows you the patients. Obviously, I can't do that on this show. So you could get a care coordinator to ring up those patients and say, I can see that you've got a statin on your repeat prescription, but you're not collecting it. Do you know why? And they might say, well, I've just forgotten to take it and I'm happy to restart it again. Or they might say, oh, I've had terrible side effects from that, in which case the care coordinator can refer them to the pharmacist or someone else. And the second people are the people who are on lipid lowering, but they haven't had any checks for their cholesterol in the last 15 months. So the care coordinator could book them in for an appointment. The second group is optimization issues. So this is where you're going to need a clinician. All of this could be done by a pharmacist or a nurse practitioner with appropriate training, or a GP or other appropriate professionals. So you've got the first group is people who might want to think about starting lipid lowering therapy. So I've got 265 people in my practice who we probably ought to be offering lipid lowering therapy to. And this little split here is separating people out into those who are more likely to have inequalities. And that's looking at all sorts of things like race, language, mental health problems, veteran status, a huge number of markers of inequalities. So if you wanted to do some work on reducing your inequalities, these would be the searches to use. Then we've got people who you might want to think about intensification. So I've got 256 of those. Priority one is these people who are on low intensity statins and they haven't said they don't want to move up to higher intensity treatment. And you can even separate that out, so you only include people who haven't achieved the target that you want to achieve. This section here is a project that we ran, which was really successful, where you can take people who are on low intensity statins, who haven't been on anything else. You can select the patients. You can send them a comms annex through the System 1 comms annex message, and it'll send them a text or an email saying, looks like you might not be on the right treatment to maximize your benefit. Are you interested in improving your treatment? And they reply. A task comes back into the practice that you can assign to whoever you like, and then you can very quickly and efficiently titrate those people up to a high intensity statin. And we did that with our pharmacist, and it worked really well. Okay, so that's the primary prevention section. Then you've got a secondary prevention section, which is basically works exactly the same, except the intensification section's a bit more complex, because it starts off with people who are on low intensity statins. There's also a section to consider people to think about moving to very high intensity statins. And then you've got sections for inclisiran, PCSK9 inhibitors, icosapent, and I've included reluctantly the QOF bit at the bottom if you just want to work on the QOF target, although I don't think it's very sensible. There's a separate section if you specifically want to be thinking about inclisiran and PCSK9 inhibitors and icosapent. There's a section for this group of people who need risk assessment. So I've got 185 people in my practice whose risk is probably more than 10% who haven't been assessed. I can split that down if I want to those people who might be harder to reach, might need to work harder to engage with, or I can separate it out into other groups. So I can choose the highest risk people. There's 5 people whose risk is 20% or more. I can look at the people who are eligible for a health check, so I can target those people for an NHS health check if you deliver NHS health checks. I can look at people who've got an existing long-term condition review, so I can try and catch those people when they come for their long-term condition review, or I can find the group of people who don't have any long-term conditions or are not eligible for NHS health check, who we might need to make a special effort to get in touch with. Finally, on here, there's a QOF section. So this has got the 4 indicators that are related to lipids. And you've got 2 columns, one for how does this look at the end of the year. Not very sensible to look at that column until you're getting into the last quarter of the year, because it's not really accurate until then. So this is the how am I driving one. It tells you what the rule is, how you can achieve it, how you can accept patients, and then reports to help with that. So I've got 22 patients who are not achieving cholesterol 1. 7 of them are already on a lipid lowering treatment, but because of the way the business rules are set up, you have to accept them from the statin, because it wants them to have a statin first before you consider a lipid lowering therapy. So I would need to go into those patients and see if I should be recording statin not tolerated or refused or adverse reaction. Similarly, people here who are severely frail might want to think about adding an exception to say that lipid lowering therapy is really not in their best interests. And you've got cholesterol 2, obviously no benefit there for exceptions, because you can't do any exceptions, but it does split your patients out into people who are not achieving this either because they haven't had their lipids checked. So all you might need to do to achieve these patients is get them in and have their lipids checked, whereas these are the people who haven't achieved the thresholds for that QOF indicator in the last 12 months. And then the same for the 2 diabetes indicators. Okay, so I'm just going to get rid of that screen, come back to the presentation. Right, just going to skip past these because I just put these slides in case I couldn't share my system 1 screen. This is an example of that mail out that I was telling you about. So this is a screenshot of what you get on your mobile, a message to the patient saying, looks like you might benefit from a change in your medication. Do you want to think about it? And they can tick yes or no, and it just comes back into the practice. So I think it would be sensible, before I go on to the tools that we can use for individual patients, just to see if there are any questions about the dashboard to start with.
Yeah, there was one question, Gareth, about accessing the dashboard that I think Ben has dealt with in the chat. If not, can somebody please add to the chat and we'll pick it up. There was a question about what to do with patients who are less than 10% cardiovascular risk by virtue of their age, but whose non-HDL is greater than 2.5. So what do you do with young people whose non-HDL is greater than 2.5, but their CVD is less than 10% due to age, is the question.
So if they've got cardiovascular disease, then they should be treated irrespective of their cholesterol, because everybody with established cardiovascular disease should be on some sort of lipid lowering therapy. If it's people who haven't got cardiovascular disease, atherosclerosis, then until recently NICE says, well, you work out what their Q risk is, and if their Q risk is less than 10, is more than 10, then you offer them a statin, and the absolute level of their cholesterol doesn't actually matter. So you might have someone who looks like they've got really quite high cholesterol, and unless it's kind of familial hypercholesterolemia territory, you don't need to treat them. The more recent update to the NICE guidelines says you could consider lipid lowering therapy in people whose Q risk is less than 10%, but I'm not entirely sure how you have that discussion. I think it's just a discussion of, I guess the easiest way to do it is the old Cates plots, and it's a 25% risk reduction, and patients can choose if their risk is 8% and they want to go for a 2% reduction, then that's up to them.
Okay, Amit's got his hand up. We'll just take that briefly.
Yeah, just on that, what I would do with a patient, I would take a really good family history. If they have a very strong family history and want to go on a statin, NICE allows us to do that, so I would do that. The other thing I would use is the Q risk lifetime score, which you can Google, get, and if they have a high Q-RIS lifetime score, then I would offer them a statin as well. So just, there's just another couple of things I would personally do, and many of my lipid colleagues would do.
Thanks,
Amit.
Thank you.
Amit also had a question of, I think, with regards to searches about bempedoic acid and plus or minus ezetimibe. So what about that combination?
What's the question, Amit?
What about
just, I didn't see you had inclisiran, you had everything else, but you didn't have bempedoic acid and ezetimibe.
So
in that the searches eligibility.
So in terms of eligibility, that would be included in those patients who you're thinking about need intensification.
Okay. Yeah.
So for the primary prevention patients, those people who haven't achieved their 40% reduction in non-HDL cholesterol, and for secondary prevention, depending on what target you're using, it'll come up in those searches.
Gareth, to be who uses less than 40% reduction? Because every time I lecture, I ask the audience, to put their hands up. No one puts their hands up.
So I find why
we don't quaff. So I don't agree with less than 40%, but that's what NICE says. It's being revised, and there is absolutely no doubt the less than 40% will go.
So the current consultation from NICE is to have a target for, well, not for primary prevention though. It's only been consulted on for secondary prevention.
Yeah.
And the current consultation is for less than or equal to 2.6 for non-HDL cholesterol, which is different.
Less than 1.8.
Yeah, but the way the business rules work, if you've got a non-HDL cholesterol, then the LDL cholesterol is ignored, and that's the same in the business rules for QOF. So in our region where we get non-HDL cholesterol in our pathology reports, the LDL cholesterol will have no impact on the QOF target.
Okay,
yeah.
Thanks.
We do get
question.
LDL, I think, in Darlington, don't we?
Yeah,
we get LDL, but because we get a non-HDL, the LDL doesn't count.
Okay.
There's another question, Gareth.
Yeah.
Can the patient be on ezetimibe, bempedoic acid, and a statin? So all three together?
I don't know. It's not something I've prescribed.
Yes, I've prescribed a lot of that. Yeah, there's it's licensed to be prescribed on top of statin, and so if you don't achieve target, you can use statin plus bempedoic acid plus ezetimibe, which we certainly do in secondary prevention to achieve target. So yes, you can prescribe it, and it's safe to do.
Okay, another question just come in. I think this will be for patients who've got secondary prevention cardiovascular disease. If the patient is not on atorvastatin 80, but the non-HDL is less than 2.5, will you still need to increase the atorvastatin from 20 to 80?
So my practice is that we should be aiming for very high intensity lipid lowering if we can for patients who've got atherosclerotic cardiovascular disease. And that's part of my worry about having a fixed target for non-HDL cholesterol, because there's a risk that you might say, well, they've achieved the target, we'll just stop where we are, especially if their baseline non-HDL cholesterol was quite low. So you have to take that into consideration alongside the patient's wishes and their comorbidity and their renal function and all those other things. But I'm happy to take any other people's views on that practice.
Okay.
Yeah. I would aim for 80 because the TNT study that compared atorvastatin 80 to atorvastatin 10 showed a reduction in every single mortality and morbidity parameter. And that's why we recommend atorvastatin 80 if possible. Some won't tolerate it, and 40 is better than 20 in my opinion. So and that's regardless of LDL, because all the trials were done with LDL, non-HDL.
I think that's all the questions we've got at the moment. Maybe some more come through, which is absolutely fine. So Gareth, do you want to continue?
Yeah. So moving on to, for the individual patient, to try and help work out what's going on with the individual patient. This is the lipid optimization view that we've built in System 1. So this is an example of a patient, and you can see hopefully everything you need to know about lipid lowering for this patient on this screen. So we can see that it looks like this patient's primary prevention patient, and we can see their Q risk is 35%, and we can see that they're more than 60 years old and they've got diabetes. And we can see the most recent lipid results: total cholesterol, HDL, non-HDL, LDL, and triglycerides. We see the result and when it was done. So we can see, looks like it's done within a reasonable length of time because it's green. That's been done in the last year. But we can see that the results in red, because they haven't achieved the target. So their 40% target risk target is 3.4. We can also see the patient not taking the treatment that they have been prescribed, and that they haven't achieved their target. If you click on this little drop-down button, you can then see more detail of the lipid results. So you can follow the trend for the various lipid results. So we can see, and these little blocks here are lipid lowering prescriptions. So we can see this person's been started on this. This happens to be atorvastatin 20 milligrams, which in the real thing you could hover over and it would tell you. This is just a screenshot. So you can see that the person did drop down a bit, but basically hasn't been taking the treatment very often since then. So their lipids have gone right back up again. If you click on the lipid prescriptions with lipid results button, then you get a list of their results and their treatment. And that's really helpful when you're trying to work out what treatment they've had and what effect that had on their lipids, and also whether or not they've been collecting it. Obviously, you can't tell if they've been taking it for definite, but if they didn't collect it, they definitely didn't take it. At the top here, you'll also get a summary of all the drugs they've ever had before. So we can see this person has only had atorvastatin 20 milligrams. They haven't taken it very much, and understandably, they haven't had much success. So if we take this person here, this person's got primary prevention, looks like they need primary prevention, 11% Q risk. You can see their current results, but it's suggesting they haven't got a target, and you might want to add a target. We can see the most recent prescriptions of atorvastatin here. And if you click on the target button, you'll get a screen which shows you the lipid results, and you can check to look what their pre-treatment lipid results were, and record in this box their target non-HDL cholesterol. And there's a calculator there which you can use to, it's very simple, 0.6 times their pre-treatment non-HDL cholesterol. And if you then put that in, you can see, you can go back to their screen, you can see their targets now displayed, the cholesterol's gone green, and the little red alerts disappeared. This is just get that one. So this is a screen when, so from this bit here, from the green bit, lipid lowering therapy, will give you the various options for treating that patient. This little button here will drop down the treatment potency table. So if you want to check what the potencies of the various treatment are, you can drop that down. And then we can see if the medicine's in yellow, it means they've had it in the past. If the medicine's in green, it means that they're on it currently. And if the medicine's in red, it means they've had an adverse reaction to that medicine. So we can see this person's in atorvastatin. It will have relevant information. So it's saying this person's got CKD. So really, you usually would be thinking about starting with 20 milligrams. Lots of other alerts will come up on here. For example, if they're on amlodipine, it would tell you, only use certain doses of simvastatin, and so on. If you click on the on the add 10 milligram button, it'll add 10 milligrams of atorvastatin to their repeat prescription. If you click on the pink button, it'll send them a message with a patient information leaflet, or you can use a drop down to actually print it out. And then there's the schedule task button, which will send a scheduled task back to whoever you decide in 3 months to check their lipids and their LFTs. The other treatments are down here, and if the patient has meets the criteria for the other treatments like inclisiran or PCSK9 inhibitors or caspent, this bit will be green. So here's an example of a patient who's got coronary heart disease. Their most recent cholesterol is quite recent, but their non-HDL cholesterol is not controlled. Their 40% reduction target is less than 3.1. We can see they're not achieving QOF, not achieving their personalized lipid target, and they've potentially got a criteria for thinking about inclisiran. You can see they're currently on bempedoic acid with ezetimibe. Lots of adverse reactions in the past. We can see reactions to atorvastatin, bravastatin, rosuvastatin. And then if we go down to their screen for the options for treating them, we can see the ADRs from previous treatments. We can see that previously atorvastatin, tried bravastatin, tried rosuvastatin, currently on ezetimibe and bempedoic acid, and they appear to meet the criteria for inclisiran. Okay, so also on this visualization is built into it is the pathway. So that is, just go back and show you. So this blue bit down here, you can either use the hyperlink to the national guideline, or you can click on, just drop down this menu, and it will give you the current NICE guidelines and the bits relevant for that patient are highlighted. So we can see this person's blue, secondary prevention, the eGFR is normal, so you can, and it looks like they're eligible for inclisiran. There's a series of additional opt-in resources which people can have if they want. So probably one of the most useful ones is a little alert that comes up on the toolbar to say, think about starting this person on lipid lowering. And that's either primary or secondary prevention. So you can think about targeting those people opportunistically. There are targeting and safety reports that will fire when you start someone on lipid lowering. So checks that they've had the right treatment, checks if you want to record a lipid target, checks if they have got on contraindicated medications, that sort of thing. And will also prompt you to fill in a questionnaire just to make sure you've given them the right information about the risks. So in summary, there's a large amount of potential patient benefit. There's a massive amount of work, but what we're trying to do is to break this work down into bite-sized chunks which you can delegate. If I was going to start with anything, I would start with people who are not taking their current medication, secondary prevention, people who are not taking lipid lowering, people on who need primary prevention who are not taking their lipid lowering. We can break that down into the highest risk people, the highest risk people who need cardiovascular risk assessment, and then that remote intensification mail out that I was talking about earlier on. And that's where I'll stop.
Okay, thank you very much, Gareth. That is very clear. There were a couple of other comments in the chat about the use of bempedoic acid and ezetimibe together with a statin. Accepting it is licensed, but it's not recommended in the NELA guidelines, and that the NICE TA 694 suggests to only use when statin is contraindicated, but it is licensed. There's an access problem as well about accessing the windows displayed on slides 22, 24, and 27 that I think Ben has or will pick up. So if we can stop sharing your slides, Gareth, and Emma will just put on the other slides, I think. Okay. Firstly, I would like to thank Gareth very much and all your participation and everything everybody's done, putting questions in the chat for that session. Very useful. If you've got any other questions that you think of later, do get in touch with us and let us know. Hopefully you've managed to identify some action points that you can take away and think about for within your own practice. We've got future CVD lunch and learn sessions. These are going to cover the broader cardiovascular disease prevention agenda, as well as CKD in due course, and there'll be one probably in January, February time, so look out for those. They're intended to be over a lunchtime. The next one, the date's to be confirmed, but we anticipate talking more about the QOF cholesterol targets and an update about the Neely guidelines. There is also a webinar next week about statin adherence. It's running 12 till 1. If you've not had an invite to that, please get in touch with us. But it's being run jointly between ourselves and Health Innovation Yorkshire and Humber. And I think will be a very informative, useful session as well, because statin adherence and overall drug adherence, as we know, is quite a major issue for us. So thank you very much, everybody. We're bang on 1 o'clock, so we'll end the session there.